Of cystic lesions of the pancreas. This is a topic that has been somewhat close to my heart for many, many years. But before I begin, I do wish I could have been with you guys in person, but obviously that's not going to happen. This is the next best thing. I also wanted to thank the organizers for the invitation to speak to you guys this morning or this afternoon, as the case may be. I'm particularly thankful to Dr. Venkat Iyer, who actually I did my residency with at AIIMS many, many decades ago. So thank you again for the invitation, and let's get into it. So a lot of what I'm going to be talking to you is the collective experience of a large number of people, and this includes endoscopists, surgeons, pathologists, cytopathologists, and folks who do basic research on pancreatic cysts and pancreatic cancer in general. We have a pancreatic cyst conference every month or so at Mass General Hospital. And a lot of what I'm going to talk to you are things that I have learned during this multidisciplinary conferences. There's one thing I want you to take away with, and that is you will not or should not be working in isolation. The diagnosis of a pancreatic cyst is based on the collective wisdom of all of those wonderful physicians around you. So I am going to divide my talk into two halves. The first half will talk about the principles of diagnosis of pancreatic cyst fluid cytology, but no such talk can be complete without talking about chemical analysis of cyst fluid, some basic interpretation of pancreatic cross-sectional imaging, and some management issues. And what I haven't mentioned here is now becoming the 800-pound gorilla in the room, and that is molecular analysis of cyst fluid. And on part 2, we'll apply some of these principles to this analysis. Now, most fine needle aspiration biopsies of the pancreas are done through an endoscopic approach. If you remember percutaneous FNAs of the pancreas, then you're probably as old or perhaps even older than I am. Traverses. Most pancreatic head masses are approached through the duodenum. Most lesions in the body and tail are approached through the stomach. Now, this is the problem. As that needle traverses either the duodenum or the stomach, it picks up, and at times a lot of epithelium from the surface of the GI tract. It can be very scant, but it can be very abundant, and this is what we refer to as GI contamination. Fortunately, it is uncommon to see this degree of GI contamination. And I know this is GI contamination because this was an FNA from a serous cyst adenoma, which is not lined by mucinous epithelium. Fortunately, in most cases, GI contamination, in this case this is gastric contamination, appears as these very flat monolayers, very monotonous cells, well-rounded nuclear envelopes. The chromatin is fine. No one in their right mind is going to think that this is malignant. But the problem when you're dealing with a pancreatic cyst is that a significant proportion of pancreatic cysts are IPMNs, and a significant proportion of those are lined by low-grade gastric epithelium. And as you can tell, it is virtually impossible to tell this gastric type IPMNs lined by foveolar epithelium with these cups of mucin from epithelium from the surface of the gastrointestinal tract. And therein lies the crux of the problem when you're dealing with pancreatic cyst fluid analysis. The duodenum actually can look a little more worrisome because the duodenum, as you well know, is often shows this very reactive appearance, particularly the first part of the duodenum. So they may get some slightly rounded up and dark, but notice how monotonous the cells look, and you'll often see goblet cells staring at you. When you look closely at a flat monolayer, you'll invariably see these lymphocytes on the surface These almost appear as sesame seeds, and this is helpful because IPMNs almost never have intraepithelial lymphocytes. So GI contamination obviously comes in many flavors. It can be slight, it could be abundant. This is of course very degenerated epithelium. My guess is these are pyloric type glands that are falling apart. And elsewhere, this is again gastric contamination. They can show a slightly more reactive appearance. Notice this sort of slightly chaotic arrangement of the cell. Notice this foveolar cups of mucin here. And it is, as you well know, it's not uncommon to see reactive changes in the gastric mucosa. So this turns out to be a huge pitfall when you're evaluating pancreatic cyst fluids. GI epithelium could be virtually indistinguishable from a neoplastic mucinous cyst. And this is something that has helped me a fair amount. My gut reaction when I see a flat monolayer of epithelial cells that look completely benign, my gut reaction is to call this GI contamination. Unfortunately, you can also see mucin that comes from the surface of the GI tract, obviously confusing it from mucin that appears from a neoplastic mucinous cyst. Now, when I use the word neoplastic mucinous cyst, I'm clubbing intraductal papillary mucinous neoplasms, IPMNs, and mucinous cystic neoplasms, MCNs, into one basket. And the reason I'm doing that is because cytologically, you simply cannot tell the difference between those two cysts. Now I know this came from the gastric surface, and you often see these stripped epithelial cells embedded within it. In many cases, you can actually tell the difference between mucin that has come in from the gastrointestinal tract and mucin from the neoplastic mucinous lesion. Neoplastic mucin, if you allow me to use that word, tends to be more viscous, tends to be more lamellated, and tends to be more abundant. But at times it can be virtually impossible to tell the difference between the two. In general, here's a pearl. If it is more abundant, if it's lamellated in viscosity, it's almost certainly neoplastic mucin from a neoplastic mucinous cyst. Fortunately, I think with all of those ancillary tools that we're going to be talking about shortly available to us today, this is not a huge diagnostic issue. So if there's one thing I want you to walk away with at the end of this talk, if you remember nothing at all, remember this one thing, that you will not and you cannot make a diagnosis on cyst fluid in isolation. You have a ton of friends. You will not make it in isolation. And this is what is referred to very frequently as the multimodal approach of pancreatic cysts. So you have a number of friends. Now, at your particular institution, you may not have all of these, but at the very least, you need to have some clinical information, because if this patient has obstructive jaundice, that's a totally different ball game. Your radiologist is your next best friend. Chemical analysis, particularly cyst fluid CEA, is extremely helpful. And the new kid on the block is, of course, molecular. But I cannot stress this enough, that you will not make a diagnosis of cyst fluid cytology in a clinical vacuum. No, you will not. So there's a number of guidelines that incorporate all of those modalities we spoke of. So they put it together and give you a sense of who should be operated and who should be not. There's at least 3 major guidelines. There may be others that I'm missing this. So you've got to ask yourself, why this explosion of guidelines? The reason is that pancreatic cysts are incredibly common. Think of it. If you are 70 years old, 40% of you may have at least a small pancreatic cyst, right? Scary thought, right? But here's the good news, most of them are benign, and you do not want to be resecting these pancreatic cysts. Most of them are benign, and you've got to remember that pancreatic surgery is associated with significant morbidity, but more importantly, there is still that 1% mortality associated with pancreatic surgery. So we want to choose our patients who go to surgery very, very carefully. And finally, most of these patients are on the older side. There are many comorbid conditions, and these are not great operative risk candidates. So we want to decide what we want to do is we want to only resect those that absolutely need resection, those that are at the point of invasion or have invasive carcinoma, and we want to observe all of the others. And that is our goal, both in a global sense, but for us as cytopathologists. So I'm not going to bore you with all of these guidelines. This is the Fukuoka guidelines, and I'm just going to highlight a few things for you, right? So these guidelines are telling you when to resect and when to observe and when to let that patient go. So, for example, if you look at this, if a patient has obstructive jaundice, that person goes to surgery right away. If he or she has a lesion in the head of the cystic lesion in the head of the pancreas, where do cytopathologists figure in this? Let's look at that. Here we are. So if the cytology is suspicious or positive, or in cytology speak, if you have high-grade atypical epithelial cells, those patients go directly to surgery. So that's where we come in. If we say that the cytology is suspicious or positive, high-grade atypical epithelial cells, that person goes straight to surgery. So here are your specific goals as a pancreatic cytopathologist. One, to make a diagnosis, and I use the word when possible because in many instances you will not be able to make a definitive diagnosis. But even more important than that is identifying these advanced cysts, and you will do that by identifying high-grade atypical epithelial cells, and we'll talk a lot more about this. So just a very few quick words about imaging. I'm not a radiologist, and I have no intention of making radiologists out of you. There are four broad patterns, and I'm giving you the 10,000 high view on this topic. The one pattern I would highlight is the presence of a solid nodule. The presence of a solid nodule in a pancreatic cyst is very concerning for malignancy. So as you can tell, many of these patterns are relatively non-specific. So a unilocular cyst could be one of four things, and perhaps a few more. This particular pattern, this microcystic pattern with the central scar right there, is virtually diagnostic of a serous cyst adenoma. So occasionally, radiology can give you a definitive diagnosis. A macrocystic pattern, on the other hand, again raises a relatively broad differential diagnosis. And finally, the solid component. So a solid nodule in a cyst is very concerning for a malignant IPMN, but it could be a couple of other things, all of which, interestingly enough, probably need to be resected. So chemical analysis can be extremely helpful, and it was our go-to assay for many, many years before molecular assays came along. So this was a wonderful paper back almost 15 years ago, and what this shows is that CEA is extremely helpful in identifying an IPMN or an MCN. But notice there is a range, right? A CEA of above 800 is virtually diagnostic of an IPMN or MCN, but you will notice a couple of pseudocysts and serous adenomas in that range, and therein lies some of the challenges in interpreting a CEA, a cyst fluid CEA. The amylase levels, this is pancreatic cyst fluid amylase, as you can see, is all over the place. But I will highlight just this area for you. Notice that virtually all pseudocysts have an amylase greater than 250. So I'm getting old, and then the older I get, the fewer things I can remember, and this is the cheat sheet that I carry at the back of my head. If the CEA is more than 200, that's very, very suggestive of a neoplastic mucinous cyst. If it is less than 5, it's very unlikely to be a neoplastic mucinous cyst, and therefore it is more likely to be one of these other benign cysts. And finally, there is only one use to the amylase, and that is, if it is less than 250, it is not a pseudocyst. Molecular testing is now the 800-pound gorilla in the room as far as pancreatic cyst fluid testing goes. And so you can see very early promise of molecular testing in this paper going back to 2009. But next generation sequencing has changed all of that. Now that is the technique that we use in our lab. Next generation sequencing, if you would give me a minute, did two things. One is it greatly increased the sensitivity of the assay, and you do need a sensitive assay because remember, within that cyst fluid there is DNA from GI contamination, there's DNA from inflammatory cells that outpaces the DNA from the neoplastic component. So you need a really sensitive technique. And so you can have as few as 5% of neoplastic cells in that mix. And next-gen sequencing will pick that up, something that Sanger sequencing couldn't do. The other big change, of course, is with next-gen sequencing, you can identify multiple genes in a single test. You can look for KRAS, you can look for GNAS, you can look for P53, which you couldn't do with Sanger sequencing. So this has been quite a game changer. I borrowed this from a review from Artur Singhi. It's a lovely review in case you want to read it. And it sort of highlights a couple of things. One is there's a couple of mutations, KRAS, GNAS, and RNF43, are quite characteristic of a neoplastic mucinous cyst. Two, there's a couple of mutations that's virtually diagnostic of an entity. So VHL with serous adenoma and beta-catenin, that's the gene that encodes beta-catenin, in solid pseudopapillary neoplasms. But even more exciting than that is the fact that there is some mutations like P53 and SMAD4 that are indicative of an advanced pancreatic cyst. These are cysts with high-grade dysplasia or invasive adenocarcinoma. And so that is truly exciting. So what next-gen sequencing allows us to do is to distinguish IPMNs and MCNs from non-mucinous cysts by the detection of KRAS and GNAS, and as you can see from the sensitivity and specificity. But the most exciting part of this is this ability to distinguish advanced pancreatic cyst, albeit with a lower sensitivity. Cytology and the detection of atypical epithelial cells that we'll talk about next is far more sensitive in detecting advanced pancreatic cysts. And then finally, it can definitively diagnose certain cysts such as serous adenomas and solid pseudopapillary neoplasms. So all of this plays into what we do with the cyst fluid. Now clearly this is very precious material. You do not want to waste it on assays that do not work. Testing for molecular analysis, as you saw from those amazing results, takes precedence. The molecular lab requires about at least 0.3 cc's of fluid. It's sent to them fresh after vortexing. What's left of the fluid is then spun down, and if there is enough material available, we'll send this off for CAA, and if greater is available, then for amylase testing. The rest of it is spun down and a cytospin slide is created. Now we prefer cytospin because it leaves the cells relatively untouched. We prefer not to use a thin preparation. Cytospin works pretty well, primarily because these samples are not particularly cellular to begin with. If they are very cellular, you could spin it down and make a cell block preparation. That works quite well as well. So let's look at a series of cases. This is going to be case one. This is a patient with abdominal pain, and if you look at cross-sectional imaging, believe it or not, this is the pancreas, and this is a massively dilated main pancreatic duct. Really, even though I'm not a radiologist, I can tell you that this could be nothing but an intraductal papillary mucinous neoplasms. So let's look at the guidelines, the Fukuoka guidelines. And they suggest that any neoplastic mucinous cyst with these features, either obstructive jaundice or a dilated main pancreatic duct, should go directly to surgery if the patient, of course, can tolerate surgery. This particular patient has two strikes: obstructive jaundice, dilated main pancreatic duct, and in theory should go directly for surgery. However, he did go to an endoscopist who put a scope down. This is the ampulla, and you can see this patulous, what is referred to as a fish mouth ampulla, producing tons of mucin. Again, this is a diagnostic appearance for a main duct IPMN. These patients, because of the very high risk of surgery, generally go straight to surgery. But it was aspirated, and here's what the aspirate looks like. This is classic mucin, right? This has that viscous quality, that lamellated appearance, that abundance. This in no way can be GI contamination. In addition, there were cells that look like this. Notice the irregular nuclear membranes, the slightly drunken honeycomb appearance, and this abundant this sort of pale cytoplasm, all very characteristic for an adenocarcinoma. A CEA level was tremendously high. That should come as no surprise whatsoever. So this is how I would sign this out. Positive for malignant cells. This, in the right clinical context, is consistent with a main duct IPM. And again, now I'm incorporating the radiologist's opinion into my report, as well as the cyst fluid CEA. We did not have genetics on this. I'll point out to you that I think this is important, more important than ever, to put this line in, and that line is invasion cannot be excluded, because the vast majority of our pancreatic cancer cases now get preoperative neoadjuvant therapy, and I want you to remind your clinicians that we in cytology cannot distinguish an invasive for a non-invasive process, and so this patient in theory should not receive pre-op chemo radiation. So the final diagnosis comes as no surprise. This is an IPMN, and this on histology also showed an invasive adenocarcinoma. All right, so let's talk about case 2. This was a relatively older man with absolutely no symptoms. This was detected during cross-sectional imaging for something entirely unrelated. Here's the MRI, and you can see the cyst in the body of the pancreas. Here's the cyst on MRCP, and you can see that the main pancreatic duct is slightly dilated, but here's the cyst that is continuous with the main pancreatic duct. This is virtually diagnostic for a branch duct IPMN. The cytospin preparation definitely shows mucin. The thin preparation is sort of so-so. It isn't great. I probably couldn't really call that mucin. But the cytospin preparation shows this thick, rather viscous appearance with the pseudopod-like processes and that very deep blue color, which is quite characteristic. There are a couple of cells here that look relatively banal, but there were other cells, as shown here, that had this very three-dimensional appearance. Perhaps there were some nuclear envelope changes, but relatively high nuclear cytoplasmic ratios and that three-dimensional appearance, that certainly concerns me. But before we get to this case, let's talk about how one makes a diagnosis of a neoplastic mucinous cyst. And I like to sort of split it into two distinct diagnostic questions. One, is this a neoplastic mucinous cyst? And if it is a neoplastic mucinous cyst, what is the grade? Is this low grade or is this high grade? Because high grade will buy me, or buy the patient, a resection. So let's talk about question number 1. How does one make a diagnosis of a neoplastic mucinous cyst? And these are the 4 pillars to make a diagnosis of a neoplastic mucinous cyst. We talked a little bit about imaging. On cytology, you're looking to make a diagnosis of a neoplastic mucinous cyst. You're looking for mucin, and this is pretty obvious mucin, as we just talked about. This mucin was also positive for mucicarmine and was also positive for algin blue. The question is, do you actually need these stains? And the answer is no. You do not require these stains to make a diagnosis of a neoplastic mucinous cyst. In fact, they could be more of a problem than a help, because occasionally other things, such as this case, this pseudocyst here, was positive for mucicarmine and algin blue. So do not waste your precious fluid on mucin stains. And that fluid that you get from your endoscopist is indeed very, very precious. Typically you get very small quantities of fluid. So unfortunately, you see this mucin in only about 50% of cases on smears. Chemical analysis, specifically cyst fluid CA, is far more sensitive and perhaps a little specific as well. But perhaps even more sensitive than either of those techniques is the detection of KRAS and GNAS mutations. Using a next generation sequencing platform, the sensitivity for detecting a neoplastic mucinous cyst is in the 90+% range. So cytology is the least sensitive means for detecting neoplastic mucinous cyst. CEA is slightly more sensitive, but perhaps the most sensitive technique is molecular analysis. they are fairly specific, all three of these modalities. All right, so we're going to switch gears and talk a little bit about grading these neoplastic mucinous cysts. Clearly, the presence of a dilated main pancreatic duct or a mural nodule typically reflects an advanced cyst. The detection of high-grade atypical cells is very suggestive of an advanced cyst, and the presence of any of these mutations is also suggestive of an advanced cyst or a cyst with high-grade dysplasia or invasive adenocarcinoma. But in this case, molecular is relatively insensitive for the detection of an advanced cyst. Cytology is far more sensitive and perhaps just as specific for a diagnosis of an advanced cyst. So how do you identify these high-grade atypical cells? So these are the criteria that have been suggested to distinguish low-grade epithelium from high-grade epithelium. Small cell size as measured by either a red blood cell or a duodenal enterocyte, high nuclear to cytoplasmic ratios, marked nuclear membrane irregularities, that hypo or hyperchromasia of the chromatin, and background necrosis. But as you can imagine, this is not a task for the faint-hearted. This is very challenging. And here's why the detection of these atypical epithelial cells is so challenging. One, these samples are very hypocellular, and the few cells you see are macrophages. Two, and this is a intraductal papillary mucinous neoplasm. Two, these cells are typically have been floating in the mucin for prolonged periods of time, and therefore they show significant degenerative changes, such as in this cluster here. And so they're innately hyperchromatic, not because they're neoplastic, but because they are degenerated. And finally, remember, the needle traverses the lumen of the gastrointestinal tract, and not infrequently you have ulcers and erosions on the surface of the gastrointestinal tract. And imagine a needle traversing through these large atypical cells. That is recipe for disaster. And finally, there's significant heterogeneity within that lining epithelium itself in an IPMN, so it could vary from gastric to intestinal to pancreatobiliary. So there's a whole host of challenges. Finally, of course, there is the IOPN, or the oncocytic variant, which is now considered a separate type. So this is what your task is, to identify these high-grade atypical epithelial cells in pancreatic cyst fluid. Huge challenge. And remember, the stakes are very, very high. I don't want to put the fear of God in you, but it is true. The stakes are very, very high. If you call it high-grade atypical epithelial cells, you will buy that patient a pancreatic resection. If you call it low grade, very likely, if there aren't any other bad features around, very likely that that patient will get a follow-up. So let's talk a little bit more about these high-grade epithelial cells. And now that you've been listening to my talk for so long, it's time to get to do some work. I'm going to put you guys to the test. So I have a series of cases, and what you're going to have to decide is whether they are high-grade epithelial cells or not. So this was an elderly person, 4-centimeter mass, that could buy this patient a pancreatic resection based simply on the size. The imaging was very suggestive of a branch duct IPMN. What the surgeon really wanted to know is, are there atypical epithelial cells here? Now, this has abundant mucin, and it has that spider web-like configuration. That mucin makes this a neoplastic mucinous cyst. In this instance, an intraductal papillary mucinous neoplasm. Now, there were cells in here. That is not the appearance, even on low power, that is not the appearance of GI contamination. And there were a couple of fragments that looked like this, right? There's one cell that is very easily visualized. Here's another cell. And I remember very early on in my cytology education, I was told that if you divide the cell into 4 halves, and if you see the chromatin different in each of the quarters, that is a feature of neoplasia. And by that rule, this is certainly very, very atypical. And there are these nuclear membrane irregularities. Atypical epithelial cells, anyone? Indeed, we did think these were atypical epithelial cells, and in fact on resection this turned out to be an invasive adenocarcinoma arising in an IPMN, and that's pretty easy, isn't it? So let's look at case B. Now this time an elderly man who presented with abdominal pain, probably unrelated to the pancreas, and those symptoms prompted a CT scan. And here's the lesion here. It was in communication with the main pancreatic duct. It was a cystic lesion. No mural nodule was identified on EUS either. There's the lesion. The question for you is, are these high-grade atypical epithelial cells? Now this looks like a relatively flat sheet. I don't think the chromatin is very well preserved. The nucleocytoplasmic ratios are pretty low, the best I can tell, particularly with cells around here. But there were a couple of cells that looked like this, tiny clusters where the nucleocytoplasmic ratios were high. These were relatively small cells when measured against red blood cells and intestinal epithelial cells. This was called atypical epithelial cells. Just some more analysis. Interestingly enough, there was no mucin seen. The CEA was very low. However, what was then called the red pad test, which is nothing but Sanger sequencing for KRAS, did find a mutation. That mutation squarely makes this a branch duct IPMN along with the radiological information. Notice the CEA was extremely low. Now, what was interesting is that this patient could not undergo surgery. It's been more than 10 years since this read. The cyst has not progressed. I would label this as a false positive result. It is sometimes challenging to distinguish between low-grade and high-grade atypical cells, and I think this case illustrates that problem. So cytology is fairly good at identifying these high-grade atypical cells. However, you will see a few false positives. So case C was more of a clinical challenge, and this is primarily because this patient had a prior history of chronic pancreatitis, or felt to be chronic pancreatitis with alcohol intake, and so the possibility of a pseudocyst was raised. Here's the cyst on a CT scan. There was some calcification in the background pancreas, but when the endosonographer went in, aspirated this material, it was mucinous. This is very important because when you see gross mucinous fluid, that is near diagnostic of a neoplastic mucinous cyst. And indeed, when the endoscopist smeared this across the slide, it was thick, viscid material. It looks like classic mucin. So it's a neoplastic mucinous cyst. We did have a positive mucicomin stain on this patient as well. What is interesting is, in spite of all of that mucin, the CEA was extremely low. And this is what happens occasionally when you have very thick, viscid mucin. The lab cannot analyze these samples. You could argue that we really didn't need this mutation to make a diagnosis of a neoplastic mucinous cyst. Now, I'll remind you that in spite of the fact that there was all this mucin, there were no epithelial cells. By that, we would imply or assume that this lesion is low grade. Unfortunately, it was not. Here's the resection. Here's the cyst filled with this sort of papillary frond-like material right here. And here's the histology. It's a papillary lesion lined by intestinal type epithelium with high-grade dysplasia. So this would be classified as a false negative, and it is not uncommon to see FNAs that do not capture areas of high-grade dysplasia. So cytology is an imperfect test, and you may not capture foci of high-grade dysplasia in your fine needle aspiration. All right, so let's do two more cases. This is a 4.5 centimeter cyst in an elderly man, and this time on EUS we noted a solid nodule. There was very little fluid available for analysis, and the endoscopist just smeared it on the slide. So there was no ancillary testing possible. But the presence of that solid nodule is very concerning for malignancy. And this is what the smears look like. One, there were foci of necrosis in the background, which is very concerning. These were cells with very high nuclear cytoplasmic ratios, and you can see perhaps maybe on this slide, if not on the next slide, you can see nuclear membrane irregularities. They were covered by necrosis and cellular debris, so it made it hard to see, but these cells are very concerning. These cells are definitely atypical epithelial cells, and on resection this turned out to be an invasive adenocarcinoma arising in an IPMN. And here's the final case in this series. This time around it's an elderly woman, incidentally detected cystic lesion in the head of the pancreas, and that becomes important for a reason. Here was the lesion, 26 millimeters in the head of the pancreas. It grew by almost a centimeter, which then pushed the gastroenterologists to get an FNA. And this is what the FNA showed. Absolutely no mucin at all, which often happens in an aspirate from an IPMN. But of concern were these cells. Now, there's sort of a flattish monolayer. They're clearly columnar. There's no mucin in these cells, but they seem to have, where you can see them, a fair amount of cytoplasm. The question is, are these cells atypical enough for you to call them high-grade atypical epithelial cells? And in my book, when you get a good look at these cells, they seem to have relatively low nuclear to cytoplasmic ratios. I do not see convincing nuclear membrane irregularities. The chromatin seems quite normal, although there is some material at the back here that looks a little like coagulative necrosis. Now, I think it is these cases where there is some debate whether this atypia is sufficient to call them high-grade atypical epithelial cells. And that's where cyst fluid cytology gets extremely challenging. Well, long story short, this turned out to be low grade. And so here's the cyst. You can see a single layer lining epithelium. And if you take a higher look, it's lined by mucinous type epithelium. This was a branch duct IPMN, gastric type, low grade. And what is interesting is if you go back to these cells now, these cells do not look like the cells from the lesion, implying that these cells were likely from the duodenum. So this is gastrointestinal contamination mimicking atypical epithelial cells. And with that, I hope I've illustrated for you that some of the challenges associated with the cytology of pancreatic cysts. So what a long and meandering journey. So let's go back to our case 2, if you still remember that we did have a case that we were discussing. Here was the FNA. It certainly showed mucin. Mucin defines this as a neoplastic mucinous cyst. And the question was, are these high-grade enough to be called high-grade atypical epithelial cells? And in my book, they are. They have relatively high nuclear cytoplasmic ratios. I think they are nuclear membrane irregularities. And I'm particularly concerned by this three-dimensional appearance of these cells, something that I obviously cannot illustrate for you right now. So we did call these high-grade atypical epithelial cells. This is how I signed this out with high-grade atypical cells. And then I go on to say that the atypical cells would support high-grade dysplasia. And I also add that cytology cannot distinguish between high-grade dysplasia and invasive carcinoma. This turned out to be on resection IPMN with high-grade dysplasia. So we did get this right. One of the messages I'd like you to leave you with is do not ignore these tight three-dimensional clusters that are composed of these relatively small cells with very high nuclear cytoplasmic ratios. These are very suggestive, not always, but very frequently are associated with high-grade dysplasia. So let's talk about this 44-year-old young woman who presented with very mild abdominal pain. And here's the cyst. It was in the tail of the pancreas. It's fairly sizable, as you can tell. This sort of embraces a relatively broad differential diagnosis, a unilocular cyst, although this is more likely to be a mucinous cystic neoplasm at this age and at this location than any of the other considerations. So there's the needle within the cyst, and this is what the needle brought out. Absolutely no mucin whatsoever. Very few cells, just one cluster of cells, and I'll let you decide whether you think these are atypical or not. There's relatively low nuclear to cytoplasmic ratios. The chromatin looks fine. I'm personally not very taken by these, although the original pathologist did refer to these as atypical. Fortunately, even though there was no mucin, the CEA was elevated. Not as elevated as I would like, but nevertheless it was elevated. What was really helpful was the detection of a KRAS mutation that squarely placed this as a neoplastic mucinous cyst. Very likely a mucinous cystic neoplasm given the location and the age. And what is the grade? I think this is probably going to end up low grade. This is how I would sign it out. Most importantly, the diagnosis is based on a multimodal approach. I make the diagnosis of a neoplastic mucinous cyst not based on those glandular epithelial cells, because potentially they could be GI contamination, although I don't think so. Certainly the KRAS mutation squarely placed this in the neoplastic mucinous cyst category, and most importantly, I did not see any high-grade atypical cells. This was the resection, a unilocular cyst. This was indeed a mucinous cystic neoplasm. Here's the ovarian type stroma. Remember, you do not make a diagnosis of a mucinous cystic neoplasm without the presence of ovarian type stroma. Alright, so let's look at case 4, 65-year-old with abdominal pain, although it's very unclear if that abdominal pain was actually related to the cyst. This is a case where radiology trumps everything else. This is very classic for a serous cystadenoma. Here is the central scar, and here are these little cysts surrounding that central scar. Rounded, bosselated mass. Here's the endoscopic ultrasound image. This, I believe, there was very hypocellular smear. This, I believe, is gastrointestinal contaminating epithelium. Regardless, it looks very banal. What was striking, and was the only thing found here, were these hemosiderin-laden macrophages. There you go, those hemosiderin-laden macrophages. The CEA was 15, the amylase was 15. Question, is this a neoplastic mucinous cyst? Probably unlikely. The imaging looked like a serous cystadenoma, and the CEA was just not high enough. How about a pseudocyst? That was certainly raised as a possibility, but the amylase is under 250, so very unlikely to be a pseudocyst. Is this a serous cystadenoma like the radiologist suggested? But where are the epithelial cells? This is a classic serous cystadenoma. This is what you normally see with these lining cells. Very characteristic, thick cytoplasmic membranes. They almost look, the nuclei look a little like fried eggs, and this very pale, clear cytoplasm. That is very, very typical. Now this is a direct smear, and you can again see these very typical serous cystadenoma cells, but unfortunately you seldom see it like that. In most cases the smears are filled with blood. These are very bloody specimens. They don't look as good as I showed you on that direct smear. Here it is on a game sustain, and on a thin prep preparation they really get beaten out and are very hard to recognize. So unfortunately, the serous epithelium is seldom seen on an FNA. It turns out that hemosiderin-laden macrophages are actually an excellent surrogate marker for a serous cystadenoma, and that is because this tumor is very vascular, therefore they bleed, and therefore you have hemosiderin-laden macrophages. And this was a paper that we wrote just a little about a decade ago, which showed that hemosiderin-laden macrophages are a fairly good surrogate marker for serous cystadenomas, rarely seen in a neoplastic mucinous cyst. So it's helpful, but not 100% sensitive and not 100% specific. So this is how I would sign this case out. And of course, we did not have genetics at the point we signed this out. I said consistent with a serous cystadenoma primarily because the radiology was so extremely clear. Case 5 is this time as a relatively young woman, at least in my eyes, with another incidentally detected pancreatic cyst. Here's the pancreatic cyst right there. It seems to have a rather thick wall. It was aspirated, and this is what we showed. Clusters of cells, very round, very monotonous, but most importantly, there was a couple of adhesive cells with this moderate amount of cytoplasm, but they have this oval nuclei with very fine chromatin. Now, obviously, when I see oval nuclei, I think of a solid pseudopapillary neoplasm, regardless of whether I see grooves or not. But I can tell you that when you see a monotonous tumor like this from the pancreas, monotonous round tumor, these are the possibilities that you must consider. And I borrowed these infograms from Karen Pinto. This is a book that we are writing together. It's on surgical pathology and cytopathology of the pancreas, but it has a lot of these infograms. And I bring this up here because solid pseudopapillary neoplasm is typically a tumor of young women, and this would fit into that category. Cytologically, you classically see these branching fragments, which we did not see in this case. This is what those branching fragments, this is that pseudopapillary appearance of a solid pseudopapillary neoplasm. Here's another view, this time on GIMSA. The central core of those fibrovascular pieces of tissue will show this very magenta colored cores of tissue. Again, notice that antipolar appearance of the nuclei. The nuclei are not associated with the core, but instead are further away from the core. The differential diagnosis includes an acinar cell carcinoma. Classic acinar cell carcinomas again come off as adhesive cells like a pancreatic endocrine tumor, but unlike most other round monotonous tumors, they tend to have this very granular amphiphilic cytoplasm and these big cherry red nucleoli. But I had an acinar cell carcinoma a couple of weeks ago that had neither of these features. So clearly you need immunohistochemistry to back this up. This is more of a classic pancreatic endocrine tumor. Again, notice that very adhesive appearance. Some of these tend to be very vascular, and the neuroendocrine cells actually smear at the edges of that vascular network. Now, most but not all pancreatic endocrine tumors will have that classic salt and pepper chromatin appearance and plasmacytoid appearance. Some pancreatic endocrine tumors can have a very homogeneous, fine chromatin network. So when you have you're suspecting a solid pseudopapillary neoplasm, as in this case, and you see oval nuclei, it's probably based on those oval nuclei and the lack of those nucleoli. Is a solid pseudopapillary neoplasm is likely, but the only way you can confirm that diagnosis is using immunohistochemistry. And this is the immunohistochemistry for those 4 common monotonous round cell tumors. And the immunohistochemical stain that is virtually diagnostic of a solid pseudopapillary neoplasm is nuclear beta-catenin reactivity. So I hope we have convinced you that at least some of these aspirates from pancreatic cysts can be a huge challenge. Not all of them, obviously. The other thing I wanted to point out that the incidence of these aspirates is only going to increase. If you think they're going away, you've guessed wrong. If you don't see any of these cysts right now, you will see them in a couple of years. If you see them, I can assure you your numbers will double. And that's primarily because we are dealing with 2 things. One is an aging population, and 2 is an increased use of cross-sectional imaging. But I do believe we have a very important role to play. We are in the driver's seat in many of these cases. It is we as cytopathologists that will decide which pancreas remains behind and which patient ends up in the hands of a surgeon. I did want to briefly touch upon my social media presence. Everyone has a social media presence today. I have a fairly active Twitter account where I post images on cytopathology, GI pathology, and bone and soft tissue pathology. I also have a very active YouTube channel where I post a number of videos on cytology, GI pathology, and bone and soft tissue pathology, and I have some very interesting projects coming down the line, including interviews with very well-known GI and bone and soft tissue pathologists as well as cytopathologists, where they, and that's right, I'm saying this right, they walk me through slides on challenging topics such as Barrett's esophagus and pancreatic cyst fluids. So do tune in. Again, thank you for the invitation. Thank you for listening to me, and good night.